Thank you, Chairman Barrett, members of the committee. Luke McNamee, Indiana Hospital Association. So much like in the Senate side in the first half, we are here to share our support for this bill. We continue to support 225, and we would like to share some, I think, additional changes that we think the bill makes stronger that we've shared with Senator Bush in the first half. So hopefully nothing is too new. First off, and it'll get a little technical, so I apologize. I can give you page numbers if you prefer. But the first change would be extending the date for what is considered a medical debt from 60 days, what's in the bill now, to 120 days. So that stretches out the timeline for a patient who's on a payment plan from something being considered a debt 60 days in, stretches it out to 120. So it gives that patient more time. The next one, Section 4, subsection 3, big Section 4, subsection 3. So references to the list of things that trigger this law. One of the references is 1621.18, which is the reference to the requirements last year that we codified in House Enrolled Act 1004 as it relates to the statewide average benchmark that a hospital has to be under in order to maintain their nonprofit status. So it was our understanding with that legislation that the goal was to put it upon the hospital to decide whether or not they wanted to remain a nonprofit hospital by meeting that statewide benchmark. The way we read this is that essentially takes that the choice and turns it into effectively a price cap, because if we fail to meet that, now we're unable to collect medical debts. So it would compel any hospital, nonprofit or otherwise, to meet those requirements. So we would request striking that language. And then finally, we would request you all shorten the time frame for the notification. We agree that notification is important. Patients should know if there is a reduction of the service line and the hospital is going to close. We completely agree. But we just think 120 days is too long. Hospital services, service line closures and hospital closures are really delicate things. Timing is really delicate. You have to inform staff. You have your board meetings to make the decisions about what comes next. To Senator Bush's point, you have to plan to help send patients where you're going to send patients to those services that they're typically that they're used to receiving. So we would suggest that there are some federal regs that recognize 30 days. We would love 30 days. I think we would even be comfortable with 60 days. We just think 120 days is a little too long. With that, I'll stop. Happy to answer any questions, or I can touch on any of those other items or where they are in the bill if you're interested.
Before I ask a question, I'll tell you I found some other names, so there's some people that are signed up that we'll hear after you. Any questions for Luke? Representative Hostetler.
Thank you, Mr. Chairman. I got a multi-part one. So what's what actually happens by your request to stretch it from 60 to 120 days? What's the
timeline of the notification timeline?
Not for the notification for the closure of service, but the medical, or
what is defined as medical debt?
Yes.
Yeah, so the way we look at it, if you're a patient, you come in, you're on a payment plan, and it's structured to be longer than 120 days. But then this bill triggers, and now suddenly the payment plan that you're on could be construed as medical debt, whereas we consider medical debt like a past due amount that's not actively being paid on. I think that's the difference.
You know, I think there's
that's
also
the way we're conceptualizing the.
I think there's also an issue is that anyone's had a procedure done. You may still be sorting through the EOBs at 60 days and trying to make sense of what's going on. I don't think it's unusual to wind up getting a bill more than 60 days out once it goes through some of these gyrations with your insurance company and all. So, but it's something that we can kind of talk about.
And so would it also, so if that happened, then all these payment plans, so say someone has a $9,000 payment plan and it's going to be stretched out for 2 years, then with that language, then that wouldn't be seen as medical debt anymore, right?
So I think that's what we're trying to make sure doesn't happen here, is that if there's a patient on a payment plan that suddenly we're not able to collect on something that is otherwise going perfectly fine. Like I'm making my payments to the hospital on a regular basis, but all of a sudden, 60 days out on a 2-year plan, now all collections have to cease on something that was done done relatively recently, and everything is otherwise going okay. So if it's clarification, then maybe that's a fair approach also, but we just thought bumping the days out would be the simplest way.
So it would still be, So if a hospital had people on these payment plans, then that would still be something that registers that it is a debt. I mean, it is medical debt that people still have just because they've assumed a payment. It doesn't mean that.
Sure.
So it wouldn't be a way to hide that, hey, there's 1/6 of Indiana has medical debt.
Yeah, I think what we're trying to do here is just make sure there's a really clear delineation between something that the patient and the hospital are actively working together on, and something that is a balance that's past due and not being paid upon, and something that could potentially end up in collections because of that.
And so if they've made a payment, so like, is there something that triggers whether or not they're on the path to payment?
I don't know if I understand that
Because
question.
just different scenarios of different people, down around, before when Deaconess sells something to MedFirst Solutions, and then they have, a certain period of time until something happens, and they've been making payments towards something. They haven't set up a payment plan, but they've been making payments as they can, and then Med1 Solutions says, hey, you have until this time, but at the same time, your Deaconess portal is still open. You can make payments to Deaconess when Med1 Solutions, and that also confuses some people when they say, my portal tells me I owe this, and they tell me I owe this, and I'm making payments in my portal, but it's not being reported to. And that might be something that the practitioners can say, hey, we've already sold this debt, but we're still. I guess there's probably some kind of agreement once Med1 Solutions starts knocking on your door. If Deaconess continues to collect payment, they probably have to forward that on to Med1 Solutions, I assume,
Yeah,
or something like that.
And that's where I think to your question earlier about the selling of medical debt. Excuse me, still recovering from an illness. Selling a medical debt, as I understand it, they're typically assigned, so they're not actually sold. So I think to your point, Deaconess would still have somewhat of an involvement in there, and what we see is individuals who end up in collections often turn around and call the hospital and try to get back on a payment plan. That's been another issue we've been working on a lot this session, 1271 in particular. But it's an interesting nuance here, and I think maybe the way that the bill is worded, it does, I think, prohibit a hospital and a debt collector from pursuing debts. So even in a kind of a goofy situation like that, I think if the hospital was out of compliance with the statute, the debt collector would then be precluded. But I don't know how that rubs with if the debt is sold. So it's a good question, but.
So you said that the hospital would be on the hook and the debt collector wouldn't have. There's no repercussions at all for the debt collector.
Well, no. So I'm saying that if I'm reading this section correctly, now we're on the fly here. On page 3, big section 5, subsection 3, a hospital or debt collector or third party on behalf of a hospital may not pursue collection of medical debt unless the hospital's. So I think in your scenario, if Deaconess were to even, whether they assigned it or sold it, and Deaconess is suddenly out of compliance, that they would be incumbent, or it would be incumbent upon them to tell the debt collector that they can't make.
Okay.
I think that's how this would operate, but
Okay.
I don't know. I defer to Senator Bush or the LSA attorneys if I'm spinning out too far here.
Yeah. Thank you, Luke.
Are you worried that, like, when medical debt then is turned over or reclassified, that somehow it loses its classification as medical debt and now becomes something else?
No, it's not even the person. It's just if it's an outstanding debt that can't be paid at all, then is it viewed one way. Whereas if you've got a not-for-profit that says, hey, we've got $200,000 a month we're receiving in medical debt payments, will it still be reported, and still, like, is that something that you can still see, hey, there's not debt, nobody's credit score is being destroyed and nothing's being taken from them, but there's this debt which is different than all other debt in the United States. If I go buy a car, if I go buy a house, I kind of know what the price is before I go there, and it's negotiated, whereas medical debt is, I don't know of any. I'm sure the argument could be made for plastic surgery, things like that, but this is a totally different scenario. This type of debt, I'd say 1/6 of Hoosiers, probably 80 to 90% of those, conservatively, weren't seeking this debt out and didn't sign up for it voluntarily. And I just don't want, in some way, shape, or form, for there to be this huge sum of collections going on, or payments going on for past debts, that is not viewed and not understood to be, this is a debt that's still being taken care of, even though it's not a default or quote unquote bad debt. It is still something that, in addition to exorbitant insurance and utility and every other cost, there's this medical debt, and that's constantly growing and being put on our backs. And I just don't want that to find a way to get lost in the weeds.
Thank you. Representative McGuire.
Well, and this is kind of, I think, in response to yours. I was looking into, or trying to find out about medical debt, and I don't think we actually track debt as medical debt. Like, we aren't tracking that. It's kind of through surveying and a lot of other means, but I don't think we can go to a court dashboard and total up medical debt for the state of Indiana. So, again, so I think we need to be doing that, but I don't know that it would even make a difference. But I totally agree with you, though.
Well, and if I may, there would be even a subcategory of hospital medical debt versus other provider medical debt too, and that's the other kicker here. Not to say that, I'm not standing up here saying that there are, other folks have higher rates of medical debt or not, but there simply isn't a way to track it at the moment.
Representative Shackelford.
Thank you, Chairman. I just got a question on section 3G in regards to the hospital being able to retroactively go back and collect the medical debt once they were non-compliant, and
Sorry,
then they
can
become.
you point me to where you're?
So on page 4, and if you look at G,
Okay.
and it's saying that the hospital may pursue collections that occurred when they weren't compliant, but now they are compliant. So my question is, what does that time frame look like? Because now you have a hospital that was out of compliance with the State Department of Health.
Mm-hmm.
I don't know how long it's going to take you to get back compliant.
Oh, okay. I
But
understand.
then for you to then be able to go back and collect that debt from an individual, is there deadlines already in law that keeps you from going back, say, 2 or 3 years when you weren't compliant?
So I appreciate the question. I think on the timing of how quickly, once we are compliant, we would be able to start collecting again, get that decision from the department or from the AG, and then now we know we can continue doing that. Your question is a fair one, but I think based on the reports that are listed in here, and there are a number of them, as far as I know, when a hospital is not compliant with these reports, and they almost, I've been told that it is 99.9% of the time that they're compliant with these things. And when they do miss the deadline, it's only by a couple of days, typically, on some of these things, or most of these things. So I just candidly I don't foresee a scenario where we're 3 years behind on turning in our Schedule H or our hospital fiscal report that we do every year, the Medicare cost report we do every year. So if that's something that needs to be added just for safety, but I don't see that being an issue going back that far.
That's something we're looking at in
Thank
an
you.
amendment to protect the patient. And if you look on page 3 of the bill as it's written, you get down to small section 2, lines 35, 36, 37, 38, 39. Those are the requirements that a hospital has to meet, and they're not like static requirements. These are reports that are due on certain dates, and to his point, 99+% compliance on that. So we need to look and just see if you're compliant for the year, you're compliant for the year. If you're not compliant for the year, then you still have time. We have penalties on delayed reporting and all kind of things to make sure that this is not the case. So one's an indigent charity care report, one's a community benefit report, one's a posting of shoppable services on websites. One is Schedule H reporting. So they're not really fluid reporting requirements. They're one time, once a year, turn your report in thing. But we are looking for clarity on that, so there's not a churn in this category. Hey, I have debt, I don't have debt, now I have debt again. And we're just trying to get some protections in that amendment.
Okay, so your amendment is so I see the reporting is due. Is your amendment then going to address how far they can go back?
The amendment's going to deal with how often this status happens, so that we don't have somebody flipping off having medical debt and flipping back on the next day. So I think indirectly it will address your concern.
So it sounds like your amendment is these reports, you're going to basically have maybe the State Department of Health looking at a hospital annually or once instead of.
They already are. That's when these reports are all due. They're an annual kind of review process.
Okay.
I believe each and every one of those are annual requirements.
I believe so.
Okay.
The one I'm not completely sure on, to speak out loud, is that shoppable services, the website posting thing. That's more of a,
I don't know how frequent that is, or if
Yeah.
that's just on a, as it's reported kind
maybe
of
you
basis.
can look at
but
that and
sure.
get clarity on that. The others are like, these are due on certain days. And the agency bill we had last week actually addressed, one of the pieces of that was to kind of correlate the dates of reporting with the federal requirements as well, so that there weren't staggered reports.
Okay. Well, I'll wait to look at the amendment.
Okay.
Thank you.
Representative Garcia-Wilburn.
Thank you, Mr. Chairman. I do want to circle back to Representative Hostetler's comments, because I don't think we closed the loop there, and I would appreciate clarity. So regarding the reassignment of delinquent medical debt to a hospital, and it has then been sold to a third party that deals with delinquencies, how is that categorized? Because I think Representative Carbaugh was on trajectory to say it is categorized as personal debt. Is that correct? Is that correct? Is it then categorized as a personal debt, a personal liability, a delinquency which would impact credit scores, et cetera?
I don't know the answer to that. I don't know if anybody can speak to that.
Can you turn on your mic, Julie? I'm sorry.
Yes, it's my understanding medical debt affects credit scores.
Right, so it is then considered a personal liability, a personal debt. It doesn't have this magical medical classification that protects us from harm,
Right.
financial harm.
It's bankruptable, yeah.
Exactly. Thank you so much, Representative. I appreciate that. Is that a correct understanding, Mr. Chairman, do you think?
I don't have that understanding. I think that would be just the easiest way ever, just to scrub debt of medical debt. I mean, I think, but I don't have clarity in that.
Okay.
So I don't want to speak to that.
There's a little bit of confusion. Thank you.
Yeah.